Hello, everybody. I just wanted to talk to you today a little bit about promoting mental health assessment in clinical practice. I think this is an incredibly important and key element in the care of HIV patients, but also in stopping the epidemic. As we deal with an aging population of patients, we notice that we still have very significant complications in terms of mental health. I have no disclosures related to this presentation, and my objectives are to describe the comorbidity between HIV and mental illness, discuss the complexities of diagnosing major depression, and discuss addictions as a major barrier to the eradication of HIV, hepatitis C, and Hep B. I'm hoping that this will help you improve identification and treatment of comorbid mental illness in clinical settings. So those are the points I want to make today. We right now have this goal of HIV eradication. And in order to do that, we have to get patients undetectable, which means we have to treat the conditions that increase the risk of poor adherence and treat conditions that are barriers to engagement with our patients. We also have to stop person-to-person transmission, which means we have to treat the conditions that increase the risk of person-to-person transmission of HIV and get PrEP to vulnerable populations. Even if we found a cure for HIV, which we are working on, we would still need people to take it. And John Bartlett, many, many years ago, said that direct-acting antivirals for hepatitis C were going to end the hepatitis C epidemic. And I said, yes, just like we've ended the gonorrhea and syphilis epidemics. Problem that we face is that there are a variety of reasons, many of them mental health reasons, that people don't get good treatment, don't engage with care, and are not undetectable. So in order to get this viral epidemic under control, we have to get people to accept treatment. And that often means treating their comorbid mental health problems. HIV is a disorder that's spread by behaviors. So risk behaviors are strongly influenced by vulnerability. And the major psychiatric vulnerabilities that I want to talk about today include psychiatric diseases like major depression, bipolar disorder, and schizophrenia, behavioral disorders, and I'm going to talk a little bit about addictions, problems of endowment, personality disorders, and cognitive limitation, and problems of life experience like poor coping, limited choices, and poverty. And I think that it's really important to understand that these different psychiatric problems are depression is best thought of as a disease of your brain. But behavioral disorders like addictions, you have to think about them as behavioral problems. That is, we all talk about addiction as a disease, but there's a volitional component to addiction that has to be addressed. You can't just give people a pill and expect their behavior to change. Problems of endowment and personality tend to still be the thing that burns clinicians out the most. And dealing with people who have severe personality problems or very, very limited cognition is a barrier for our effectiveness in treatment of patients. And lastly, I talked a little bit about problems of life experience. I'm not going to address this beyond the statement that you have to know your patient. Many of our patients come from limited backgrounds, have few choices, have poor coping skills, and are living in poverty. And in order to get them better, you have to address those problems in the way they limit our patients' engagement and treatment with us. So this is a complicated slide. Over on the left, I have genetic stress, inflammation, and social isolation leading to depression. And you can see the reason I have this slide in this complex way is to show you how complex these arrows of interaction are. So depression increases high-risk sex, addiction, diminished adherence, social supports, poor coping, impoverishment, and probably plays a role in immune dysfunction and inflammation. Those things lead to worsening HIV infection and the spread of HIV, but getting infected with HIV and worsening infection leads to stress and stigma, addiction, the introduction of HIV medication, which has mental health consequences for some patients, social isolation, GI dysfunction and dysbiosis, impoverishment, and chronic inflammation. And those things make depression worse. So you have this complex cycle of multiple factors, each influencing other factors that make HIV hard to treat. Now, having said that, if you treat depression at the very beginning, if you take depression out of this loop, you very much decrease the complexity of this cycle. So depression causes diminished adherence, which it leads to worsening HIV infection, which leads to diminished adherence, which leads to HIV suppress. And just this alone has been an area of considerable research. What we've shown is depressed people are much likely to be less likely to be engaged in care. Their HIV infection is worse. They're more likely to have a detectable load. They're more likely to be non-compliant with their medicines, and they're more likely to die. So depression has bad consequences for people with HIV. And sadly, it's an easy thing to detect and an easy thing to treat. I'm going to start out talking a little bit about addictions. Addiction is a major factor in our failure to eradicate HIV. We are generous with prison in the United States, and we're stingy with treatment for addictions. We have a, quote, war on drugs, which has been ineffective in killing drugs and resulted in a war on people with addictions with high lethality. This has not in any way caused a decrease in addiction as a condition, and we have not been forward thinking about how to approach the opiate epidemic in the United States or other places. The approach to the opiate epidemic has to be effective treatment for addiction. I'm not going to spend a lot of time on addiction, but I want to spend one little bit talking about addiction. So in your life, in this next slide, in your life, you have an opportunity to do behaviors. So I have environmental exposure here leading to a behavior, let's say putting on a certain outfit, and then environmental response. So if people say you look very good in that blue shirt, I'm likely to wear it more. If you say you look terrible in that blue shirt, I'm likely to wear it less. And this is learning 101, this part of it. But for some behaviors, eating, sleeping, and sex particularly, those behaviors cause a release of reward transmitters in your brain. And this reward transmitter gives you a little, yeah. And then there's a satiation phase where you don't want to eat or sleep or have sex. And then you get hungry, and then you do the behavior more. And this is a positive feedback loop, and it amplifies behavior. And unfortunately, drugs, when you take them, act right here at this reward pathway. There isn't a turn-off mechanism in your brain, and there's a huge vulnerability for this cycle to get out of control. But you don't go from being a normal person to a drug addict, at least most of the time, in 1 minute, and you're not born a drug addict. This cycle has to go around in circles numerous times. There's a vulnerability to this behavior getting out of control that has elements of genetics and social connections, religion, occupation, class, geography, and social conventions that makes people more or less vulnerable. So religious people, this cycle is less likely to get out of control. People who have high-functioning occupations, it's less likely to get out of control. Certain genetics makes it more likely to get out of control. And so all of these factors are important in understanding addiction and thinking about how to treat it. Good addiction treatment is effective. And in our clinical study, we got approximately 30% of people indefinitely sober. And that's a very good outcome for a clinic with very modest resources. So addiction is treatable, but you have to hang in with patients. One of the things that study showed is the more times we see people, the more likely they are to get sober. And if they keep coming back, we're more and more likely to get them sober. This is a model of addiction. Whoops, sorry. This is a model of addiction. This little rat is in a cage called a Skinner box. And when this green light comes on, if he presses this lever, he gets food. And once he learns to do that, you can substitute drug so that when this green light comes on, he gets drug. And when this red light comes on, he can get an electric shock from this grid under his feet. And normal rats, if both these lights are on, will not press this lever. That is, if you take a rat and you train him so that he understands he's going to get a drug when the green light comes on, an electric shock when the red light comes on, when you turn on both lights, he won't tolerate the shock to get the drug in a normal rat. However, once he's been extensively exposed, more and more of the rats will tolerate the electric shock when both lights are on to get the drug. And this is a pretty good model of what happens to people. The longer they're exposed to drugs and the more they are in a cage like this rat is, that is, the less they have access to other rats, to other social conventions, to other opportunities, the more likely they are to get addicted. In the real world, people construct this cage out of social isolation, depression, and increasing impoverishment. And that limits their opportunity to do anything but continue the behavior. So these models help us understand how to treat addiction. And what we're learning is the things that will cause this addiction to be more severe are triggers. So with this speaker, you can introduce sounds that will trigger the animal's behavior. Stress will trigger the animal's behavior, and re-exposure. So we've had many people who we've seen who have been sober from opiates for years and years, and then get a small exposure to opiates when they have surgery or come to the emergency room. And there's a recrudescence of their illness. So it's very important to understand that these models predict what we see in clinical practice. That is, you have to stay with patients and you have to get them out of what is essentially the cage that they've developed for their addiction. This is a study we did at the beginning of the epidemic. You can see it's published in 1996, although it was completed in 1992. We had a great deal of difficulty publishing because people did not believe that there was an overall 54% rate of psychiatric disorders on Axis 1. That doesn't include substance use disorders in patients coming for HIV care. But subsequent studies, study after study, have shown that this is accurate. And the vast majority of these people either have major depression or demoralization. I'm going to talk about those just a little bit. 3/4 of the patients we saw did have a substance use disorder in addition to these other conditions. Almost 20%, almost 1 in 5, had cognitive impairment, and 26% had a personality disorder. This is a very high rate of psychiatric comorbidity coming to a clinic where people are not necessarily trained to take care of patients with psychiatric pathology. This is a review that looked at depression in HIV patients. In this paper, 27% of patients receiving antivirals were diagnosed with depression. In this study, 65% were prescribed antidepressants. That is much higher than most studies have shown. Patients with depression are less likely to achieve, patients with depression were less likely to achieve sustained depression is untreated. There's a 5-fold increase in depression in men who have sex with men compared to the general population. And discrimination, stigma, unemployment, disclosure of HIV status, and material 5-fold higher incidence of depression in men who have sex with men versus the general population. And discrimination, stigma, unemployment, disclosure of HIV status, and material deprivation play a big role in that. Depression is a key predictor of non-adherence, and antiretrovirals and reductions in viral load don't seem to diminish the risk of depression. So this is a very common problem, depression, and it's underdiagnosed and undertreated in our patients. This relates back to my earlier slide. Depression causes impulsivity, impoverishment, hopelessness. It's pro-inflammatory, disenfranchises patients, and limits their cognitive ability, which leads to increasing HIV viral load and transmission. And HIV virus itself causes increase in many of these things, including inflammation and stress, but also disenfranchisement. People with a new diagnosis of HIV get subcortical injury, and they're less likely to engage in treatment. So you have to recognize that this is a cycle of HIV worsening depression and depression worsening HIV. Now, when we say depression, we mean several different things. Today, I'm going to talk about depression is divided into 2 camps. This disease kind that I've been talking about, and something I'm going to call demoralization, which is an old term for what's now called adjustment disorder. This kind of depression everybody has at some point in their life. Somebody that you love dies, somebody, you get a romantic disappointment, you have a financial setback, and you can get depressed. But this kind of depression is the normal psychological response to adversity that everybody suffers. People who are demoralized will come in and say, I'm depressed. But this doesn't respond very well to medication. It responds to remoralization, psychotherapy, encouragement, and support. These people in general are distractible from their loss. They maintain the ability to experience a reward from activities. They often have early insomnia, difficulty falling asleep, but once they fall asleep, they tend to stay asleep. There's not much family history. These are unique episodes. The person usually has a stable life course and they respond to positive events in their life. So this kind of depression is quite different than the disease kind. The disease kind of depression tends to run in families. It's roughly 5% of the general population has this condition, 1 person in 20, and it's episodic, and it produces this thing I'm going to call pervasive anhedonia, the loss of reward, the loss of from anything except maybe drugs. And so people with depression tend to come in, and if you look at them carefully, they've lost rewards. They tend to have AM insomnia, early morning awakening, can't go back to sleep, family history, episodes that are similar through their life, a disrupted life course, and they don't respond to positive events in their life very well. So when you ask them, when you do things that should be fun for you, are they as fun as they should be? They say no. There are numerous screeners out there to try to make the distinction between these two conditions, but most of them just categorize people as depressed or not. And so knowing your patient allows you to distinguish between these two conditions. If you're stuck and you don't know what to do, if you're stuck and you don't know what to do, I urge people to treat people for major depression because there's overlap, as I've shown here, and major depression is a bad condition, whereas the side effects of antidepressants for most people are fairly modest. So if you can't tell the difference between major depression and demoralization, I tend to recommend overtreatment. However, it's very important to try to detect this condition because it's common in our patients, much more than the general population. So if you take a 5% background rate, this is 20 to 30% of people with HIV. So 5 to 6-fold increased over the general population. The problem partly is when you tell people they have a mental illness, this is a very distressing thing. And the concept of mental illness is confusing because depression is actually a biological problem. It's a physical illness as much as it is mental. But there's a huge cultural rejection of mental illness in many cultures. And people with mental illness are seen as bad or as flawed or as in some ways suffering from a punishment. And everyone interprets their mental illness as caused by stress rather than recognizing it. And many patients would rather believe they're bad people than believe they have a mental illness. So the education of our patients about what depression is, that it's a physical disorder, has nothing to do with your worth as a human being, is not a punishment. It is something that is common in all populations in the whole world and represents something that's very treatable, not much different than pneumonia or diabetes. And people should be accepting of treatment. Part of the problem is we continue to stigmatize mental illness by separating HIV treatment from mental health treatment, by putting them in different clinics, and by somehow making people believe that somehow a mental illness is different than a physical illness. The last thing I'm going to talk about is personality. This is a slide from William Osler. It says it's much more important to know what sort of patient has a disease than what sort of disease a patient has. And it's very important to know that people have personality problems. These are the kind of patients that give you difficulty and are disagreeable. And getting some coaching when you have a patient who overwhelms you is key to helping you manage patients. I'm going to skip these slides. So psychiatry is an integral part of care for patients with HIV. Understanding the complex cascade of vulnerabilities has allowed us to succeed with patients. Advocacy for our patients is a big part of our professional responsibility. Integrated care for medical, psychiatric, and substance use disorders is key to HIV eradication. And since we are going to be responsible when things go wrong, we need to have the autonomy to do what's right for our patients. Thank you very much for inviting me, and I hope this is useful for you in terms of understanding the complex care of our patients.